now we'd want to start off by providing some context for today's discussion. As many of you know, strengthening health supply chain systems requires not only strong technical solutions, which I believe we all have, but also practical approaches that improve visibility, accountability, collaboration, and data use for action. Effective health systems are built through a combined strength of data, technology, and people working together to support informed decision-making and continuous improvement. So today's webinar focuses on the IMPACTT approach and how it has been implemented across different countries and contexts. And through the experiences that we'll be able to have from Kenya, Tanzania, and Ethiopia, we hope to share some practical lessons, some successes and challenges, and insights that can support learning across different geographies. Beyond the experience sharing that we'll have today, we also hope that the discussion will stimulate further dialogue, collaboration, and interest in adapting and institutionalizing effective approaches within the broader health system strengthening efforts. We would like this webinar to be as interactive as possible. Please, we encourage you as a participant to actively engage through the chat box, share your reflections or questions, and participate during the question and answer session. I would request you introduce yourself in the chat by sharing your name, your organization, and your country where possible. Note that we will just use that particular information within this context and will not be using that information elsewhere. Okay, so before we begin, I'd want to walk you through today's agenda. We'll be able to start with a short introduction to in-supply health, followed by an overview of the IMPACTT approach and the context of the three countries. We will then be having an engaging discussion questions for the participants. Then for the second part of the webinar, we will focus on country presentations where Kenya, Tanzania, and Ethiopia will share implementation experiences, key results, and lessons learned. Finally, we will conclude with an interactive Q&A session and closing remarks. So, our first presentation will introduce in-supply health and provide the context for the work behind this initiative. It is now my honor and pleasure to invite Vincent Manyilizu, Regional Manager for Supply Chain Transformation at In-Supply Health based in Dar es Salaam, Tanzania. Vincent leads the supply chain transformation domain, and as a senior supply chain advisor, he has extensive experience in diagnosing, designing, implementing health supply chain systems. Please join me in welcoming Vincent. You will have approximately 7 minutes to take us through this presentation. Karibu sana, Vincent.
Yeah, thank you, Ken. I think I'm audible. Can you hear me?
I can hear you loud and clear.
Okay. Yeah, thank you. Thank you very much. Ken, are you sharing the screen? Was it? Should I do from my side?
Go ahead, please.
Okay.
And I'll then put it on slideshow. Thank you so much.
Okay.
Go ahead, Vincent.
Yeah, thank you. Thank you. And next slide, please. So, as Ken introduced me, I'm based in the DA office in Tanzania, but currently dialing in from Morogoro, working with the PORAC for some activities here. So, next slide. So, my role is to take you through what is in supply and what we do. So, we are an East African-based advisory firm pioneering innovation approaches for improving health access and outcome through strengthening of the health systems and the supply chains. So we are an affiliate of JSI, and we work mainly in the East Africa, but we've been up in several African countries. Our key purpose is to enable communities to lead full, healthy, and happy lives through transforming health outcomes by co-creating intelligent and resilient people-centered supply chains. So at the end of the tunnel, we are seeing that through our work, we will become a leading health supply chain advisory firm for expanding access across Africa. Currently, we have physical presence, and we have offices in Kenya and Tanzania, with our headquarters in Kenya and Nairobi, Tanzania, but we have presence in Ethiopia and Uganda, where we have some staff. And across Africa, we've been able to deliver technical assistance in several countries, as seen from the map. Thank you. Next slide. So our work is structured around key four technical portfolios. We call them domain areas of our expertise. So we have the supply chain transformation domain, which leads the design, delivery, and execution of various supply chain solutions that we undertake with the public and the private counterparts. We also have the market access and shaping. This leads our market access portfolio, trying to explore new frontiers where we can deliver access to health services and make sure that we are optimizing the efficiency of the health resource that we available within the community. We have the data transformation, intelligence, and impact. Most of you are aware that our work has been focused mainly on the digital, trying to become very much innovative to bring in efficiencies in the in the supply chain. The work that we are doing is derived and delivered through digital solutions. So the data transformation, intelligence, and impacts leads that work and supports the other portfolios to make sure that our work is more digital. We have the workforce optimization portfolio that mainly supports our initiatives around capacity building, ensuring that the workforce that is involved in delivering supply chain activities is adequately equipped with tools and skills that can support the execution supply chain. So in our work, we aim to transform access and improve the performance of supply chain systems across all the countries where we work, and throughout the engagement that we do with our counterparts, through ensuring that the solutions that we come up with, or we co-create with our partners, are scalable, and they are innovatively co-created to make that they are sustainable. And whenever we do, we embrace what we call the HCD. We put the users as a priority in the design, and we work to foster ownership throughout the engagement that we do. Our work has mainly been catalytic in terms of innovation, and we work with other partners to make sure that they are scaled out. So we demonstrate value and the impact, and then we work our counterparts, mainly the Ministry of Health and other government counterparts, but also other partners to make sure that these solutions are scaled across other geographies. Next slide. So at InSupply Health, we are working across both the public sector and the private sector. So for the public sector, our work has mainly been focused on fostering data visibility and analytics. That speaks to what we are delivering today around the IMPACTT team that empowers healthcare professionals to use data to make decisions and based on root cause analysis. So data visibility and analytics has been the foundation of the work we are doing around supply chain. So, but not only that, we embed data use into ensuring that supply chain performance and monitoring and management becomes a culture within the ecosystem where we work. And also our work around the public sector has also focused on improving the supply chain skills, competence through empowering the healthcare professionals with the needed training content and the capabilities to make sure that they improve their skills around managing health commodities. But also we deliver various consultations on supply chain services around quantification, system designs, systems assessment, making sure that we support bringing efficiency into the health supply chain. The public sector facing work has been that we have supported, have engaged or involved helping understanding the market where the health supply chain is entailed, but also supporting the introduction of health commodities such as the MPSC in Kenya. We also support mining and analyzing data to make it valuable and give actionable insights for organizations that are interested in the health supply chain. Next slide. So through our work, we uniquely provide innovation and scalable solutions in delivering our solutions. But importantly, our work has been very much engaging the key stakeholders to contextualize solutions based on the problem that they are facing. Leveraging on the various learnings that we come across and collect from various work that we have done, and also as much as possible embrace technology in terms of shaping the solution that we are coming with. Overall, the human-centered approach has been our core value in making sure that the solution that we're implementing across private and public sectors ensure long-term and the future ready impact to the community that we are serving. I think this is a brief about InSupply. I hand it over to Ken to take us to the next steps. Thank you.
Thank you so much, Vincent, for that first segment. Your presentation has clearly highlighted the critical work that InSupply is doing, which is on building sustainable and resilient supply chains across Africa. The long-term sustainability can only be achieved when countries have the local capacity, we have the expertise and the institutional strength, which is needed to manage their own supply chain systems effectively. So in this regard, we see InSupply Health demonstrating a strong model that can be a strong model and making tangible contribution across East Africa. Not one thing that it's not worthy is on the forecasting and supply planning tools, the resource management approaches. You also highlighted briefly the data use practices that are helping improve forecasting accuracy, optimize resource utilization, and overall the strengthening of the evidence-based decision-making. Now, we know that these innovations are generally generating meaningful results, and I am sure many participants would be interested in learning more about them. Now, we will be able to dedicate maybe in future webinars that exploring each of the tools that we work on. Now, before we move to the next speaker, we'll be able to have some interactive session. Next. So please go ahead. So we have on your screen, there's a poll that has come. So you can be able to, before we welcome our next speaker, please just take a short while to vote. Take a moment and respond. So the question is, how familiar are you with the impact approach in your country or organization? And as that is happening, please, our next speaker is Janet McKenna. Janet is a manager within the Manager Data Transformation, Intelligence and Impact, and one of our experts in the impact approach. Janet will provide an overview of the approach and its application across the different contexts. This session is primarily meant to help us better understand the core concepts, the principles, and the value of the approach before we move into country implementation experiences. So please, as we transition, I encourage the participant to introduce themselves once again in the chat by sharing your name, your organization, and the country. Please welcome Janet, and the floor is yours. Karibu sana.
Thank you so much, Ken, and good afternoon, good morning, colleagues. So I'll take you through an overview of the impact approach. We can move to the next slide. Yes, so thank you. So the impact approach has been implemented across Kenya, Ethiopia, and Tanzania. These three countries collectively account for approximately half of East Africa's population and 60% of the region's GDP. And while these countries differ in their health systems and supply chain structures, they share a common goal of ensuring that health commodities are consistently available to the populations that they serve. And the experience of implementing this approach across this diverse context has provided us with very valuable lessons and getting to understand how routine data use can strengthen supply chain performance and support better health outcomes. Next slide. So I'll start with sharing a brief context of the Kenya's health system foundation. So Kenya currently operates under a devolved health system where the responsibilities for health service delivery are shared between the national government, and we also have 47 county governments. The Ministry of Health provides policy direction and oversight, and the counties have the responsibility for managing the health facilities and also ensuring that services are delivered through these facilities. And through this decentralized structure, it makes it particularly important that supply chain data is available and can also be used for decision-making at the different levels of the system, beginning from the facility and rolling up to the county. To the next slide. So we have our health system organized into 6 levels for Kenya, and this ranges from the community health units to the national referral facilities. And this structure creates multiple points where supply chain decisions are made and also where data is needed to support planning, forecasting, and commodity management. As a result, we have there's need for strong coordination and also routine performance review mechanisms to facilitate and ensure that commodities remain available across the different levels of care. Next slide. So we see that Kenya's health supply chain is supported by strong digital infrastructure and a centralized procurement and distribution system through KEMSA, which is at the central level. And we have systems such as the Kenya Health Information System, KEMSA, LMIS that provide visibility into commodity availability, consumption, and reporting performance. And counties and facilities are responsible for forecasting and ordering and also managing commodities based on their local needs. And while these systems have significantly improved access to data, the challenges remain in ensuring that the data that is available is routinely reviewed and also used to inform decisions and actions. I'll also take us through the Ethiopia's health system, which is on the next slide. And for Ethiopia, we have their health system built on a decentralized administrative structure that is designed to expand access and to the health services across the whole country. And the system places strong emphasis on primary healthcare and community level service delivery, which is also similar to what we have in Kenya, with the responsibilities distributed across the regional and the local levels. And through this structure, again, similar to the other countries, it requires strong coordination and effective use of data use to ensure that commodities, again, are available for seamless delivery of service. For Ethiopia's healthcare system, it follows a tiered structure that prioritizes access to service at the community level and ensuring referral pathways for more specialized care upstream. Yeah? And the foundation of the system, they have health posts at the lowest level. They also have health centers and primary hospitals, which provide the majority of routine health services across the country. So looking at the Ethiopia's health supply chain system, on the next slide. So for Ethiopia, they operate an integrated and decentralized supply chain model that is supported by the Ethiopian Pharmaceutical Supply Service, also abbreviated as EPSS. And the health facilities, they use structured reporting and requisition processes to request commodities and also maintain their inventory levels at the facility. And also they have defined minimum and maximum stock levels that guide the supply management. If we can look at what we have for the Tanzania also to give us a brief snip of the Tanzania's health system. For Tanzania, they operate a centralized health system, so different from what we have in Kenya and Ethiopia, that is led by the Ministry of Health and the President's Office for Regional Administration and Local Government. And the Ministry of Health provides the national leadership and policy direction, with the local government authorities responsible for delivering health service. And as it is with the other countries, even for Tanzania, it's important for them to ensure that supply chain data is routinely used to support the decisions that are made and ensuring that they are maintaining availability of commodities and also delivery of service. So for Tanzania, they have a 6-level health system. The next slide. For this structure, for Tanzania, it begins with the dispensaries, then progresses to the health centers, the district hospitals, the regional referral hospitals. They also have the zonal referral hospitals and the national referral hospital. And for their health supply chain system, on the next slide, they have the health supply chain is coordinated by the Medical Stores Department, MSD, which manages the procurement, warehousing, and distribution of commodities across the country. And their system is supported by tools such as the ELMIS. They have the GOT Homis, they have EPICA, which provide visibility into commodity ordering and supply chain performance across the system. And despite all these investments and technology that the country has, they still experience the same challenge observed in Kenya and Ethiopia, really working towards ensuring that the data that is available is routinely reviewed and translated into action. And that is where the IMPACTT approach has come in to be able to facilitate and support the countries through that particular process. Can go to the next slide. So like I said, all these countries have made significant investments in their logistic information systems. They have reporting tools, they have dashboards, and the staff also have adequate training to support and facilitate improving supply chain visibility. And through these investments, it's resulted in a greater ability of supply chain data and also in many cases, improved availability of commodities. However, through our experience across the multiple countries, it showed that data availability alone is not automatically or does not automatically translate into stronger supply chain performance. And one thing that was often missing was the culture in which teams routinely review data, interpret its meaning, identify root causes from what the information is telling them, and also use this information to guide decisions and the actions that need to be made. And to address this challenge, that is why we rolled out the IMPACTT approach. And the IMPACTT approach, so the next slide. So FAST IMPACT is an acronym for Information Mobilized for Performance Action and Continuous Transformation Teams. So this approach was designed to create a seamless structure within the supply chain that brings together people, processes, and tools that are needed to support data informed decision making. And at its core, the goal of the approach is really to ensure that we have the right people bringing together also the technology and processes that are aligned to deliver health products to the communities and care providers when, where this is needed. So really just to highlight that IMPACTT is not another tool, but really it's an approach for helping people to use existing data and systems more efficiently. On to the next slide. So for us, the implementation process begins with co-designing the approach and really integrating it into existing teams rather than creating parallel structures. And the teams undertake a competency self-assessments just to understand their existing strengths and also identify the areas that require support. And then this is followed by training and rollout and ensuring that teams understand both the approach and the tools that are available to support decision making. And then once we have these teams established, they routinely use data and analytics to review their performance, conduct root cause analysis, identify practical actions that need to be taken, and also monitor the progress as they continue with that process. Yeah. And one thing that I would want to point out that makes IMPACTT different is that it's not only focused on reviewing data, but really it focuses on building the structures, the skills, incentives, and also accountability mechanisms that are needed to support improvement. To the next slide. Thank you. So one of the lessons that we learned from implementation is that effective performance review requires more than technical data skills. So at the center of the IMPACTT approach, we have 4 core competencies. This includes organizing and coordination, competencies, communication, interpreting competencies, understanding or having an in-depth understanding of the supply chain processes, and also facilitating problem solving. And then together, these competencies help the team to be able to review their performance and really translate the insights that they are gathering from their data into action. And successful implementation also depends on a broader set of enabling competencies, such as leadership, relationship management, facilitation and ensuring continuous management, mobilization of resources. And while we appreciate that these competencies may exist within different individuals, their teams really work towards ensuring that they have both a balance of the core and also the enabling competencies are represented within the team. Next slide. So one of the other lessons that we also have picked during our implementation is that teams often have varying or differing levels of experience and also confidence across our competencies. And to help address these gaps, we put together a series of learning packages that can support both individual and team capacity building. And through these materials, they provide practical guidance on key competencies required for effective implementation. And these resources are designed to support continuous learning rather than one-time training. And in addition to the learning packages, we also have developed a series of self-paced micromodules that provide short, practical and learning opportunities on key supply chain concepts. And these modules allow and make it possible for the team members to be able to strengthen their competencies at their own pace, given that they are self-paced. And we'll also share the links on the chat that you could use to be able to access these micro modules so that you can also have access to those resources. So the next slide. So at the core of the impact approach, and just to mention that the impact approach is not a static model, so it's grounded in the innovate, do, review cycle that emphasizes continuous learning and adaptation. And through these, teams are able to use, like I said, the data to identify the challenges, test their solutions, implement actions, review their results, and apply the lessons. And the goal really is not perfection, but really to create a system that continuously provides an opportunity for learning, adaptation, and improvement as the teams move along. And looking at the next slide. Next slide, please. Okay, as the slide is coming up, I can just talk through it. I think since the implementation of the impact approach, InSupply has been able, and through other organizations as well, the approach has been able to really been expanded across multiple countries and also across different health systems and program, which is something that demonstrates that the core principles of routine data use and continuous improvement are applicable across diverse settings. And we've applied, or the approach has been applied across different commodity groups and programs, including family planning, we have immunization, maternal and child health, HIV, TB, and other health commodities, including the essential medicines and medical supplies. And I think the thing that changes through our implementation across country to country is really the context. And what remains usually is constant is the need to turn the data into action. That's one of the key things that we apply even as we work on contextualizing this approach across the different countries. So as we see, and as you can see in this slide and the other couple of slides that will be just highlighting what has, or the evolution of the approach across the different countries. So what we are currently implementing has been from a series of many years of implementation, learning, and refinement. And for us, the journey really begins with focusing on strengthening data use and performance review processes, and also seeing how to pull the different lessons, applying HCD and adaptive learning to help us be able to iterate and curate the implementation so that it's meeting the needs of the users and also addressing any challenges that we experience along our implementation. The same process has also been followed in Tanzania, as we can see in the next slide. So we still apply the same core principles, use of HCD and adaptive learning. And I think the only thing that I would want to highlight for Tanzania's case is the implementation model for Tanzania was adapted to align with its health system structures and the existing performance management. And we have the approach already anchored or embedded within the government systems, which is also something that we have within Ethiopia. But the principle really remains the same in terms of our iteration processes. Yeah. So for Ethiopia, we really did the contextualization, trying to find out what was existing, how do we embed it within what was existing. In Ethiopia, they had performance monitoring teams. So really what we tried to do was work around those performance monitoring teams. And now we have the pharmacy performance monitoring teams, where the gains or the strengths of the IMPACTT approach have been embedded and enhanced into the system. Thank you so much. I will pass it back to Danielson. Thank you.
Thank you so much, Janet, for that. And before we transition to the next, that is the country implementation experiences, I would want us to take you through a very brief reflection. And we have prepared two poll questions. The first is to acknowledge, is to a knowledge check based on what Janet has just presented. And the second is an opportunity for you to share your perspectives and experiences. So please open the polls. So take time and please respond to these. Yeah, the first one is, what does IMPACT stand for? And the second question, we talked about the IMPACTT approach, consists of the different components. From your experience, which components do you think is the most critical for creating a strong and sustainable culture for supply chain data use? You may select one or more. Response. Okay, so thank you for that. I would now want to go, I would want to invite Edessa Diriba from the Ethiopia Ministry of Health. Mr. Edessa is a pharmacist by profession and a public health expert with extensive experience in pharmaceutical system strengthening. He currently leads the pharmacy service desk within the Pharmaceutical and Medical Device Lead Executive Office of the Ministry of Health in Ethiopia. In this role, he oversees the National Pharmaceutical and Medical Service Monitoring and Evaluation, as well as performance monitoring initiatives that support evidence-based decision-making and continuous improvement across the health system. Please join me in warmly welcoming Mr. Edessa Diriba to share Ethiopian experiences with us.
Can you hear me?
Yes, we can hear you.
Yeah, thank you, Ken. And this and I will present what Ethiopia have experienced on this area. And thank you so much for inviting me. Now I can present here. Can you go to the next slide, please? So this slide, the overall slide of this is the implementation journey. And let me briefly walk through the three-phase implementation journey from pilot testing to nationwide scale-up. And we begin with phase one, the foundation in July 2024. This pilot was implemented in Redwa and Oromia Jarso Woreda, and the facilities were around 23 health facility, among those 2 hospitals and 21 health centers. The objective was to validate the approach and generate practical implementation. In phase two, started in April 2025, and extending the intervention to 11 additional health facilities across 2 more waradas in Oromia, Sidama regions, and this allowed us to test the model in different contexts and demonstrate adaptability. We now in phase 3, a nationwide scale up, transitioning from pilot implementation to institutionalization within the national health system. And the initiative is currently supports around 27 health facilities and is led by the regional health bureaus and Ministry of Health. In the next section, I will share the key results, achievements, and lessons to these areas. So let me briefly explain the framework shown here. And this is all about our pMT framework. And let me briefly explain the framework shown here, and which outlines how pharmacy pMTs are structured to drive continuous performance improvement. Under people, you can see under people, the pMT uses multidisciplinary approach. The pharmacy unit is a central and with participation of other departments like MECH, OPD, health information technicians, and facility leadership. In most facilities, MECH, OPD, and the community health communities are most active members. Under methodology, the pMT status targets, reviews monthly performance, and identifies the prioritize the gaps and conduct root cause analysis using tools such as fishbone diagram and the 5 whys tracks corrective actions. Under cadence, meeting lasts for 30 minutes or 1 hour or 2 hours, depending on the context, and the activities are organized into pre-meeting, meeting, and the post-meeting phases. Under the culture, the role rotation and the simple recognition mechanisms, central recognition supports institutionalization, and role rotation builds the skills and the ownership, while recognition helps to maintain team motivation. Next slide, please. So this slide is all about data use, documentation, and the escalation. To strengthen the facility level decision making, we introduced two key tools. The first tool is indicator tracking tool dashboard, which improves the data visibility by providing health facilities and World Health Office with near real time information. It displays the stock status. It displays stock status of 35 traced medicines and enabling early identification of stock issues and timely corrective actions. And the second is standardized pharmacy pMT logbook. This ensures consistent documentation of pMT activities and tracks performance over time. It records pre, during, and post-meeting activities, including request finding, KPI reviews, root cause analysis, and action plans, and the recognition activities. The logbook also supports a structured escalation process. As chair of the pharmacy pMT and a member of organization pMT, the pharmacy escalates critical issues that require higher level action. Together, these tools strengthen data use and accountability and the continuity of the facility at the facility levels. So next slide, please. So one of the earliest improvement was KPI reporting. Before the implementation, pharmacy and the supply chain indicators in DHIS2 were often underreported due to limited awareness among health information technicians and lack of structured review process. The pMT institutionalized monthly performance reviews, improving reporting consistency and accountability to assess the impact. We compared 12 months before the implementation with 12 months after the implementation, as you can see in this graph. The results show the improvement in the reporting data from all KPIs across the pilots. And for example, if you consider the pilot one, when the Redo and the Jarso, where so 23 health facilities are included in here. Reporting is of essential drug availability increased from 5%, while Western rate reporting increased by 22%. When we see the pilot 2, as another 11 health facilities, essential drug availability reporting increased, and antibiotic encounter reporting also shows a modification. So regular engagement of health information technicians through monthly reviews also helped to establish a strong reporting culture. Then the overall, the pre and the post implementation comparisons demonstrated measurable improvements in the KPI reporting, providing a stronger foundation for facility level decision making. Next slide, please. So when we come to improvement in data quality beyond the higher reporting rates, we also observe substantial improvement in data quality, and routine LQS-based data quality checks reduced invalid reports, limited major outliers such as 100% wastage rates or prescription rates exceeding 100%. So in JARSO and the radar, baseline data of 2023-24 included up to 52 valid antibiotic encounter reports following pPMT implementation. These errors steadily declined, reaching near zero across all by 2025. So importantly, LQS enabled facilities to identify correct errors before submission, and strengthening data ownership and improving reliability of information for decision making. Next slide, please. So improvement in this slide also shows improvement in inventory management. In phase one, inventory accuracy increased from 84% at baseline to 95% implementation. A similar trend was observed in phase two, and overall, these results show that routine and structured monitoring can produce substantial improvement in inventory management. So next slide, please. So the other is what this action put on patient level implication. For example, ultimately, the most important outcome is whether the patient receive medicines they need. So this is because the major goal we are working at Ministry of Health is, are we availing the products to the patient at the right time, and they are getting those medications in rational way. So the overall, these findings show that the stronger pharmacy performance management can translate is into better access to essential medicine at point of care. So the data indicated in here also indicates this. There are improvement in medicine availability at healthcare facilities, and it shows improved client prescription refill in 15 health facilities. Next slide, please. So the other key issue is in addition to availability and when you compare stock availability and stock out reduction, the improvement also translates to better product availability for patients. And as shown in the figure, the pharmacy pPMT approach strengthens supply chain performance across pilot facilities in the Rio and the Jarso. And different like RMNCH product commodities shows improvement in availability and the reduction in the stock out. These gains were driven by three practices, and the overall, these results demonstrate that routine and the data-driven supply chain management rapidly improves medicine availability and reduce stockouts at the health facilities. So next slide, please. When we see the data-driven stock exchange and availability improvement, one practical solution introduced through the pharmacy pPMT is data-driven stock exchange between facilities. As shown in the figure, pPMTs use routine data to identify facilities with excess stock and redistribute medicine to those facing shortages. So these improve availability while reducing expiries and wastage rate. So at national level, we have introduced the guideline and the directive to do this activity, and this facilitated our national effort. So the impact has been substantial. So the overall finding of this shows that data-driven coordination between facility can significantly improve supply chain and the patient access without additional resources. Please move to next slide. So when we come to rational medicine use with this approach, the pharmacy PMT approach also improved the rational medicine use, particularly the antibiotics, as shown in this slide. Inappropriate and excessive antibiotic prescribing was identified as a priority issue, and PMTs used the structure, problem solving, and root cause analysis to understand the drivers of the overprescribing and implement targeted actions. A key intervention was direct engagement of the prescribers to strengthen accountability and promote evident prescribing. So results show clear improvement, and the figures are in this slide displayed are very clear. In the overall, the finding and of this PMT effort shows multidisciplinary problem solving can improve not only supply chain performance, but also the rational use. So next slide, please. Thank you. So the reduction in antibiotic overprescribing was driven by a shift from individual to clinical decision to structured and the team-based and the continuous improvement, and the process runs in a cycle. It is a cyclic manner, regular data review, root cause analysis, and action and improvement are the cyclic process this thing follows. So the cycle embeds antibiotic stewardship into a routine facility practice and as a continuous and team-owned process. Next slide, please. So beyond the clinical and the supply chain gains, the pharmacy PMT approach has strengthened data use and teamwork and institutionalization learning, and improved data for action and improved collaboration and teamwork, cross benchmarking and health learning. Overall, the approach has generated system-wide improvement beyond pharmacy performance alone. And next slide, please. So in general, the national scale-up and the institutionalization, these pilot results have directly informed national scale-up played by Ministry of Health and Regional Health Bureau, laying the foundation for sustainability. So within this framework, the MH course, the Ministry of Health has developed a CPD accredited course on pharmaceutical and medical device performance monitoring to standardize national rollout, and a training of trainers model has been deployed through regional health bureaus to support nationwide implementation, and the training is being transitioned to e-learning platform to expand access and improve flexibility and reduce the costs. The pharmacy PMT model has influenced another department to establish similar performance monitoring teams and strengthening broader culture of data-driven improvement. As noted by regional coordinator in June 2025, the approach has generated strong support for continued expansion due to the recognition and visible service delivery. So thank you. This is what I have.
Thank you so much, Mr. Edessa, for the great presentation. I now want to welcome experience sharing from Dr. Wangia from the Ministry of Health, Nakuru County in Kenya. Dr. Simon Wangia is a clinical pharmacist and a quality assurance lead at the Nakuru County Health Products and Technologies Unit in Kenya. With over 17 years of experience in pharmaceutical and health supply chain management, he specializes in health system strengthening, data-driven decision-making, quality assurance, and optimizing health product supply chains to improve access and patient outcomes. Karibu sana, Dr. Wangia.
Thank you so much, Ken, and thank you for having me. I will go on to share the Kenya experience. And for us in Kenya, the experience has been that the IMPACTT approach has implemented across the various health systems, that is at the national, county, sub-county, and even the facility level. And what we've observed in Kenya is that when data visibility is combined with structured review processes, then you have a clear mechanism for improvements and meaningful change in our supply chain indicators. As you can see there, we have teams that meet at various levels, and there is a cadence where these meetings are scheduled so that they can be accountability, they can be prioritization of supply chain challenges, and even agreement on actions that need to be taken and progress that needs to be tracked. Next slide. And so part of what we have had in the IMPACTT approach is the visibility of data through the dashboards. We have two types of dashboards. We have the indicator tracking tool, and we also have the health products and technologies dashboards. These are very key in terms of pulling data from our routine reporting systems, such as the Kenya Health Information System. And this data is then presented to the IMPACTT teams for analysis and even for decision making. And this has helped to focus the decisions and the discussions during the review meetings to understand what the root issues are and be able to agree on solutions. Next slide. Now, we also have seen an improvement in our reporting rates and the reporting timelines, as we have had these structured interactions and discussions in the IMPACTT teams. We've been able to focus on our reporting performance, and we've been able to see facilities actually improve progressively from the time we started this implementation until now, where we are over a year in. We've seen, for example, as you can see on the chart on your right, the improvement in reporting timelines, reporting on time, from 82% to 97%, representing a 15% point improvement. Next slide. We have also gone a step further, not just in improving our reporting rates, but also improving the accuracy of our commodity reports. We've been able to see an improvement in discrepancies, such as discrepancies between the ending balance of the previous month and the beginning balance of the ensuing month, which we have been measuring with an indicator known as the absolute percentage difference. And these routine meetings bring together different program managers who manage family planning, immunization, nutrition, and various other programs. And we're able to interrogate these indicators and see where could the discrepancies be coming from. And we have been able to see, as you can see on that slide, a stark reduction in discrepancies of our reporting data, where we are able to even bring down the target to below 10%, which has been the target, which is highlighted even in one of those sub-counties there, Gilgil, which is one of the sub-counties in the county where I work. And this has really helped to strengthen reporting accuracy and ensure that the data that we are using for decision making is reliable and what we can actually trust when we make our decisions based on it. Next slide. We've also seen an improvement in HPT availability. One of the focus areas that we have had in our impact meetings is where teams review stock status, identify potential risks, especially regarding availability of essential health products and technologies, and even guide procurement, distribution, and follow-up actions. So this has allowed counties to address stock imbalances before they result in stockouts, as shown there in an example from Nairobi County, where you can see some of the maternal and newborn child health commodities that were not stocked according to plan before the implementation. And post current implementation period, we can now see that they are largely stocked according to plan, meaning more than 1 month of stock. Next slide. We've also had an impact in terms of reduction of stockouts, so that as we ensure that we have availability of essential health products and technologies, our routine impact meetings provide the teams with the opportunity to address the stockout rates. And we have seen that 8 out of 9 key tracer commodities were able to fall significantly in terms of the stockout rates, between 10 to 54% drop. And a good example is in one of our arid and semi-arid lands counties, that is Isiolo, where long distances and extended lead times can make stockouts particularly difficult to address. But when we are able to see this data on the dashboards, we're able to compare, and we're able to say, there's a risk of a stockout here. Can we redistribute? Can we prioritize its procurement and ensure that we reduce the chances of stockouts significantly? Next slide. Now, we've also been able to have an opportunity to demonstrate these results, not just at the county level, which is a devolved level, but also at the national level with the Directorate of Health Products and Technologies, where we have been able to develop key performance indicators and even performance improvement plans. And these have been recognized as a guide for the national level performance. And focal persons and data analytics teams have been appointed to support monitoring at that level. This has also strengthened the linkages and the institutionalization of impact at the national level, and supported even the counties and the sub-county teams in enabling timely follow-up of these key metrics. The other key department at the national level that we have engaged with is the vector-borne neglected tropical diseases unit, where we have also had collaboration with key stakeholders such as KEMSA, which is a national supply chain authority, and various other key stakeholders implementing impact meetings. And one of the key takeouts that we found here is that using hybrid models, we can be able to bring together teams that are in different locations, some physically, some virtually, to have these conversations. Next slide. Now, as we have continued to implement the impact approach, we've definitely had certain challenges which are expected when implementing a change initiative. And one of the earliest challenges was meeting inconsistency, where meetings would be held inconsistently. But after the training phase, we're able to address this, and teams established fixed meeting schedules, such as conducting reviews on the last Thursday of every month, which helped improve consistency and accountability. Another challenge was the action items were sometimes identified, but not followed through. And the actioning of these items was then targeted in terms of practical actions which are within the team's control, and we can be able to track them and thus be able to follow up on them. Next slide. So in summary, as we reflect on Kenya's experience, a common pattern emerges across all these result areas that I've shared. The routine review meetings provided a structured forum for teams to review performance data, identify root causes, agree on actions, and even follow up on implementation. As a result, we've seen improvements across the multiple dimensions. As you can see there, reporting completeness from 95 to 98%. We have seen a reduction in discrepancies to less than 10%. We have seen MNCH tracer commodities being available from 63% coverage to 74% coverage. And these changes and these improvements in reporting and data quality are important. Their true value lies in helping ensure that life-saving health products and technologies remain available for our mothers and newborns, for our children, and for our communities. And so Kenya's experience demonstrates that routine data review can translate information into action and action into better HPT availability and stronger supply chain performance. Next slide. And so finally, I'd like to just finish with this slide that says we have picked up certain key practical lessons, such as make data visible, so that you can be able to anchor every review on data that you can be able to review and even analyze. We've also seen that instituting a fixed cadence has also helped, ensuring that we have consistent meetings, ending every review with an action and an actionable, responsible member of the team has been very crucial. Designing for turnover has also helped us to ensure that we have learning packages that allow members who transition into the team to be able to pick up the roles when other members are given other roles and transition out of the team. So we have learned that successful implementation of the IMPACTT approach depends as much on people and processes as it does on data and technology. So we want to ensure that ultimately the IMPACTT approach is not about creating additional meetings, but about creating structured opportunities for teams to use data, solve problems, and continuously improve supply chain performance. I want to stop there. Thank you very much and hand it back to Ken.
Thank you so much, Dr. Wangia, for the great presentation. Our next presenter is Martha Kikwale from the Ministry of Health, Tanzania. Martha is a pharmacist within the Ministry of Health Pharmaceutical Services Unit and serves as the National IMPACTT Approach Coordinator. In this capacity, she oversees the implementation of the IMPACTT Approach from the regional to the health facility level, driving improvements in supply chain performance and service delivery. Karibu sana, Martha, and over to you. We can't hear you. We check on the device. We can't still hear. Maybe she's sorting. Hello. Just please keep on the questions coming, and the presenters, you can be looking at the chat. We'll have some times for adding some voice to them. Can you hear me, Martha? You are muted. So I can see questions here around the question. There is a question on the logbook. Yes. Thank you, Happiness, for supporting Martha on the same.
Can you hear me now?
Very loud and clear. Thank you so much. Please go ahead.
Okay. Thank you so much if you can hear me now. Thank you, moderator. I'm presenting on behalf of Tanzania the IMPACTT Approach implementation. Despite that, in Tanzania, we are implementing impact from national level, but I would like to share with you this evening on the implementation for primary health facilities.
Sorry about that. Maybe Happiness, consider just exiting on the other machine.
I've already.
Okay, try once more.
Sorry, moderator.
Okay. You have logged in using two devices, so I request that you switch off one of them.
Okay, just a second.
Okay, in the meantime, maybe we can, as we save the time on the question, so if we have one of the facilitators just present us to voice over one of the questions that have been talked about. So as Happiness is sorting that clearly, so we can, there's a question around in Ethiopia. I think it has been responded to, or there is the dashboard question. Is there someone who would want to voice over?
Can you hear us well now? There's no
Yes, we can hear you. No
Great.
echo, please go ahead.
Hey, moderator, can I again start sharing the experience in Tanzania? As I said before, that in Tanzania, we are implementing impact from the national level. But as far as today's session is concerned, I'll share the experience of what is happening in one of the cities in Tanzania that is in Tanga region, and is where we have trained the primary health facilities. Next slide, please. Okay, so in Tanga, we have managed to train 71 healthcare workers from 10 health facilities, but we also trained 21 regional and council management team members. And after the training, what we did is we started by monthly monitoring of the performance from May 2025. And what we do in the monitoring visits, at first, we observe what is going on with the meetings using the standardized checklist and provide feedback using the standardized feedback template. But also during the monitoring, we conduct data quality assessments across multiple data sources To start with the facilities in Tanga, we have chosen to have 4 indicators that the facilities would monitor. You can see on the right is the distribution of participants that were participating in the training, and the photos below shows the training sessions in 2 health facilities, and where in one of the facility, the district medical officer officiated the opening of the training. Next, please. Okay, going to the results that we obtain after training and follow-up of the facilities in Tanga region. One of the results is on the issue of data quality, where if you can see the graphs on the left, all the facilities shows improvement in data quality. That at the beginning, some of the facilities had the data quality up to 30%. But in 1 year, you can see the progress from March 2025 to March 2026. There's no facility that has the data quality below 80%. What did we do to achieve such results? One of the things that we did is for the trained CHMT members, we assigned them as healthcare takers for the facilities. And these CHMTs had the role to oversee the whole process of report and request preparation, from physical count to the point when they review the R&Rs before submission to MSD. But again, the team has the role to ensure that they do the data quality assessments for the collected data that were sent to MSD. And of course, out of this, we get the results of improvement in supply chain decisions, whereby the ordering and resupply planning has improved, but also the bottom-up quantification has improved. And the other area that we get the benefit out of this is the strong gains in stock tracking. This is for the issue of quantity received, stock out days, and closing balances. On the right, you can see the photo of recognizing one of the pharmaceutical technicians from Kisosora IMPACTT team, which has shown outstanding performance. And this was done during the DMO's feedback meeting. If you go back to the graph, you can see Kisosora has achieved 100% data quality. And this is not for only one period, it's for about 2 to 3 periods of review of the performance. Next, please. Next slide. Yes, regarding the no demand and overstocked items in facilities, we have seen a significant improvement again in this area, where this shows the better alignment between ordering and the actual consumptions. If you observe on the graph on the left top, you have seen the trend for percentages of no demand, where there is a significant drop in percentage of no demand for almost all facilities. And the trend is more or less similar to the trend for overstocked commodities. And this is for the period of 1 year between March 2025 to March 2026. And again, how we get these results is through the consistent monitoring visits that were done, but again, the proactive leadership engagement during the visits. We also conducted the root cause analysis using different techniques to ensure that we get the actual causes of the overstocks and no demand. But again, facilities has stopped ordering the overstocked and no demand commodities. It is as it is shown in the graph below that you can see the percentage of overstocked commodities that are ordered by facilities. At the beginning in March 2025, you can see all 10 facilities were ordering overstocked commodities. But after monitoring and implementation, only 4 facilities were ordering the overstocked commodities, but also the percentages has dropped. So this has aided in reducing the overstocked and no demand commodities. But the other thing that we did is the implementation of strategy to utilize dormant commodities like laboratory machine equipment maintenance and sharing the list of no demand commodities with clinicians during clinical meetings. The other thing is we did redistribution of health commodities from commodities which are over and understocked to over and commodities that are not used by facilities to under or stocked out commodities. And this, of course, resulted into reduction in wastage and expiry of commodities, but also improved the availability of storage space at facilities and make a good use of limited financial resources to purchase commodities, as it will be shown in the slide after this. Next, please. Yes, now this shows how the financial use has helped facilities to reduce the debt at MSD, where it has been shown that for the period between March 2025 to July 2025, facilities in Tanga City has reduced the debt from 251 to 165 US dollars at MSD. So this gives the facilities the good financial position to order other commodities that are required by the council. And on the right, you can see the photo of the district medical officer and 2 other members from the CHMT in Tanga City sharing their results in Tanzania Health Summit last year, 2025. Next, please. Okay, the other area where we get the results is the influence of impact approach in developing supply chain key performance indicators dashboard in ELMIS and other countries has said. The focus of developing the dashboard is to improve the real-time supply chain data visibility, strengthen accountability and performance monitoring, but also to fasten the data-driven decision-making across all levels. And of course, the ELMIS has now been integrated with GoToMIS to improve supply chain and service data visibility. On the right, you can see how the dashboard looks like, but in Tanzania, we have prioritized to start with few indicators of forecasting accuracy, priority, commodity availability, wastage, reporting timeliness, reporting rejection, adequate stock out, overstocking, and emergency ordering as indicators to be presented in the dashboard. Next, please. Okay, now for the 10 facilities that we trained in Tanga has now shown to own the impact approach by allocating their budgets on resources. This shows commitment and assurance of sustainability of the intervention. Below are the screenshots of the planning and the reporting system, which shows the budget that has been set for impact activities by 2 health facilities, the Ngamiani Health Center and the Tanga City District Hospitals. And these finances are from user fee and Health Sector Basket Fund. Next, please. Okay, just to wind up, is that through the implementation of Tanga City facilities, implementation of impact approach in Tanzania, we are sure that we can improve data and supply chain key performance, but also the model that we have used can be used to train other facilities as it is affordable and shows the strong collaboration between the government and implementing partners together with all other levels that are involved in implementing and oversee the implementation of impact approach. So we are ready to scale up to the nation. As I said, the model that we have used in Tanga is cost efficient. That is, we are doing the on-site training that needs a very low cost. And again, the on-site training, while doing on-site training, is flexible, that we can change the schedule for the training depending on the clinic peak hours. But also the model has shown inclusive monitoring and joint ownership that members from all levels, from the national level to the CHMT level, can participate in the monitoring of the facilities. But again, using the model, we have aligned priorities from the Ministry of Health, and again, it has shown evidence for the results to be obtained. So as a roadmap to scale up, we are focusing on finalizing monitoring of the 10 facilities in Tanga in July 2026. And we are sure that we can co-develop the national scale-up plan by integrating the impact team tools and principles into the Ministry of supervisory tools and digital platforms that are existing. For instance, the AFIA supportive supervision platform. But you can do a phased scale-up using the Tanga model, and we can establish champions of the impact approach at facility for easing the peer-to-peer learning. Having said that, moderator, I would like to thank you and thank you all members from Tanzania for implementation, but also for ensuring that impact, we get the results from the impact implementation. Thank you so much.
Thank you so much. Thank you so much, Martha. Thank you, Dr. Wangia and Dressa, together with Janet and Vincent, for taking us through this. So I'll just take request as I'm making the final comments that you could bring in the reflection questions as the poll on the reflections as we end. Just going through some of the questions, I'll not extend with more than 2 minutes, so please allow me. There is a question about the logbook in Ethiopia, which is a manual tool which is used in the facility level, how we ensure that the data is being reported. So they came up with a simple tool which was somehow used to collect the data through Excel and be able to identify, visualize this in a central place. That has been moved to right now. The facilities are using a DHIS2 platform for reporting on some of the commodities, using the electronic systems, where the electronic systems are there and just upload the report. And this is visualized to know the stock status wherever they are. The ITT, that is what we call the ITT indicator tracking tool, that is the dashboard. There is also the question around scaling up. We love to scale up through the national systems. Among the other solutions, this is the best approach that have always been used. We know that there are costs that could be associated. We've developed an onboarding solution like guide, which is hosted on the impact portal, and one is able to orient themselves and be able to institutionalize this. Just to let you know that the impact approach has been applied in the supply chain, but it can be applied in different sectors and just customized for that particular use. Otherwise, I'd really want to appreciate each and every one of you for sacrificing being here. And unless there's someone who'd want to voice over something, really appreciate. We've shared some contacts for Janet. We want to also, there's the contact, that is Ken is myself, there's Andolem for Ethiopia, and Vincent for Tanzania, if you'd want to get the country-specific information. Otherwise, we appreciate each and every one of you. Thank you so much, the great facilitators, the presenters, and we look forward to hearing more from the team. We wish you a great day for those who it's morning, and we wish you a great evening for those who are ending their day. God bless you, and see you next time.
Thank you.
Thank you.
Thank you so much.